Welcome, everyone. Rush University Medical Center, Division of Nephrology Renal Biopsy Conference for October 5th, 2023. We don't have a CME activity code. We're working on these things. It's been a little shaky lately, but we're going to clear that up. We got a fun case today. It's my case. It's a long case with several parts to it. It's actually my case and a little bit of Dr. Corbett's case from the past. We normally change everything on the case. We kept the dates the same, and I did check with the patient, and it's fine to keep the dates, but everything else has been changed to assure some confidentiality. But the dates are the same, are accurate, actually, as you'll see as we go through it. And we have nothing to disclose. And the protocol is going to be read by first-year fellow Dr. Mova.
So we have a 65-year-old man presenting with fatigue and 3-month history of progressive leg swelling. He has a history of type 2 diabetes, hypertension, BPH, and OSA. His internist wife placed him on Lasix 40 milligrams for a few days with no improvement. He complained of fatigue and decreased appetite. He denied any change in urination, fever, rash, arthralgias, or weight loss. He denied any over-the-counter medications, including NSAIDs. His wife noted diffuse lymphadenopathy in the neck. He saw his PCP, who sent him to the emergency room where his BUN was 40 and his creatinine 1.8. His urine showed proteinuria and hematuria, and he was admitted to the hospital. As far as his past medical history, he has hypertension of 10 years, diabetes of 8 years, and a recent diagnosis of BPH and OSA, for which he's on CPAP. Past surgical history of bilateral cataract surgery. His medications are Lasix 40 milligrams, vitamin D 5,000 units daily, losartan 50 milligrams, hydrochlorothiazide 12.5, and empagliflozin 25 milligrams, and linagliptin 5 milligrams. And his social history, he's a former smoker, quit 20 years ago, and social alcohol use, and denies any illicit drugs. He's married with 2 adult children and is employed as an engineer. Family history is only remarkable for diabetes, hypertension, CVA, CAD, and thalassemia minor. No history of renal disease or end-stage renal disease. On an exam, he's afebrile, blood pressure 157/87, pulse 84 and regular, respiratory rate 23, and is 73.4 kilograms with a height of 5 feet and 5 inches, and BMI of 26.8. On exam, he's alert. Only pertinent is neck that's non-tender with right posterior cervical lymphadenopathy. The IBSR crackles. On lung exam, S4, no rubber murmur, and abdomen with no organomegaly, no rash on exam, and +2 pitting edema to mid-cap. Laboratory and imaging showed a sodium of 133, chloride 101, potassium 4.2, bicarb of 23, BUN of 40, and creatinine of 1.83, glucose of 179, calcium 8.0, albumin of 2.0, alk-phos 73, T-belly 0.4, AST 28, ALT 35, magnesium 1.6, CRP 3.0, ESR 93, LDH 312, and TSH of 2.6. On CBC, he had 19.8 thousand leukocytes, and 86% of which were lymphocytes, hemoglobin of 8.6, platelet count of 118,000, and an MCV of 78.2. UA dipstick showed large blood, 26 to 100 RBCs, 250 glucose, greater than 300 of protein, and a UPC ratio of 8.6 grams. On serologic evaluation, ANA, Hep B and C, RPR, anti-GBM, ANCA, and cryoglobulins, which was done twice, were all negative. C2 was 73, C4 was 3, and RF factor was 16. All of his immunoglobulins were low, and his serum immunofixation was positive for monoclonal IgG kappa, detecting 0.4 grams per deciliter, and a kappa lambda ratio of 2.96. For his imaging, he had a renal ultrasound showing normal kidneys with hepatomegaly and splenomegaly. Chest X-ray showed bilateral pleural effusions, and echocardiogram showed moderate right and left pleural effusions and grade 2 diastolic dysfunction. A PET scan and CT showed enlarged thoracic, retroperitoneal, and pelvic lymph nodes. He underwent bone marrow biopsy, which was consistent with CLL, CD20, and CD5 positive, and he was started on steroids. His BUN and creatinine increased to 102 and 2.2 respectively. And a week after admission, a percutaneous renal biopsy was performed.
I will note this came to originally to Dr. Corbett as a second opinion. This is the information he had when he saw the patient. Any questions for Dr. Mova? All right, I'm going to hand it over to our local authority on onconephrology, Dr. Gashty. Casey, what do you think about this case?
So, 65-year-old gentleman who basically comes in with what appears a new diagnosis of CLL and has acute kidney injury with proteinuria and hematuria, has a background of hypertension and diabetes. So, more likely than not, I think that the CLL has something to do with his renal dysfunction. And in those cases, when you think about the renal diseases associated with CLL, in addition to having the actual cells infiltrating the kidney, so an infiltrative disease, indirect involvement could come from the paraprotein that looks like this patient has an IgG kappa monoclonal immunoglobulin, and those paraproteins can also cause paraprotein-related kidney disease, specifically MPGN with or without cryo. And I think since this is monoclonal, it should be type 1 cryo, although some cases, I think that type 2 cryo, like mixed cryo, can also be seen with these. These are usually low-level, low-secreting B cells, not too much unlike multiple myeloma, where the light chains can cause paraprotein-related problems. In CLL, you can see similar issues like amyloid, like AL amyloidosis, or fibrillary or immunotactic glomerulopathy. In this case, I think that the most common lesion of kidney disease that's glomerular that's associated with CLL is MPGN. So I think we're probably going to see that pattern of injury, and then kind of have to figure out if there is anything in addition to that. So in more rare cases, membranous can also be the problem. But I think that the UA here shows a good amount of blood, RBC 26 to 100, and a lot of proteinuria, 8.6 grams, and a low complement. The C4 level is low. So I think that all of that constellation of labs point me more towards MPGN. And I know that the cryo, it says, was negative twice. I'm always a little wary of a negative cryo test. So unless I see that there are no cryo on the biopsy, I'm still keeping the cryo on my differential, even though I know that the test was negative twice. And the problem with cryo is that these paraproteins are secreted at variable levels throughout the course of malignancy. So sometimes you catch it, sometimes you don't. And I just want to make sure that it's not in the tissue. So I think I'll keep cryo on the list. I'm going to stop there. I think, well, I'm not going to stop there actually, because the guy was also diabetic and hypertensive. I don't really see, I think, did he have a normal kidney function before?
Yes.
Okay, so he's on a lot of hemodynamic altering drugs, Lasix, hydrochlorothiazide, SGL2 inhibitor plus ARB. So, yes, maybe his creatinine is a little elevated because of those things, but I cannot say that 8 grams of protein with all that hematuria has anything to do with his medication. So I'm going to go with a CLL-related kidney lesion, and I'm going to pick MPGN. And I'm sort of going to be looking for cryo as well.
You alluded to the difficulty in measuring cryo, and I've said this before at conference, but not everybody's listened to every one of these. But in our day, the cryo was so sensitive to, you didn't want it to precipitate on the way to the lab, so you wanted to make sure the blood remained warm. And one of the ways we would do it is stick it in a cup of warm water and have it delivered there. The other, this might have been Steve's day, that Dr. Corbett's day, you'd actually carry it to the lab in your axilla to keep it warm. But I mean, it stresses the point that, it's very operator dependent, and this was an outside hospital. And we don't know how well they performed that test either. Any other comments before we take a look at the Before we look at the biopsy?
Roger,
Yes, Dick.
as you know, I don't like the term MPGN for a diagnosis. That's not a new statement. So I'll ask the discussant, does C4 level of 3 rule out C3GN, number one? And number two, what is the likelihood of a proliferative glomerulonephritis with monoclonal immunoglobulin deposition disease, in your opinion?
The answer to the first question is that low C4 does not rule out AC3GN. And the answer to the second question is we cannot rule out a monoclonal gammopathy, a proliferative GN. The reason I picked the MPGN pattern of injury, at least, is the fact that the patient has got a lot of proteinuria. And so I feel like there's a proliferative component, but there's also something that's causing the nephrotic component. And usually when there's that overlap, MPGN always fits best. So you're right, absolutely, that proliferative GN related to the monoclonal immunoglobulin is possible.
What about the idea that the C4 being almost undetectable might be kind of a soft clue, as we've talked about before, that it's being activated by cryoglobulins in vitro?
Yes, that can definitely be the case for sure.
That's a good point. We've sometimes used that as a subtle clue. All right. Well, let's. We have a lot to discuss today, so we're going to move along here. If we can spin the wheel. Ah, Casey. It's the Casey Gashty day.
Give you control here. Give me a second. Go ahead, click. Yep, you're controlling the
All
screen.
right. All right, so here's
remember this is an outside case, so.
Okay, so here's a low power trichrome. It's a very nice score. I see from this power, there are 2 glomeruli, which I will comment on at a higher power, but I can, at least even at this power, I can tell you that the one glomerulus looks abnormal. There's too much blue staining material, and this one is way too cellular to be normal. But I see these 2 large patches. There's this patch in the middle, and then there's this patch that's on the right side of the screen, that there is some kind of a cellular infiltrate in the interstitium. David, is this medulla?
Yeah.
Okay. Yeah, because the cells, these look more like a, there are no glomeruli, and there is some proximal and distal tubules here, but this looks more like a medullary region. But in the cortical region, there is some separation between the tubules. This could either be just fluid from the nephrotic syndrome, or it could be fibrosis. But if I had to assign a number, I would say maybe less than 25%.
Yeah, and nice job picking up on these dense infiltrates. We'll see those on higher power.
Okay. All right, here is an H&E of a glomerulus. It has the lobular pattern, looks like cauliflower, has these separations into the different lobes. It's hypercellular. I don't see very many open capillary loops. There is definitely areas where there's a different pink staining material. It's almost like a hyaline type color, and
yeah, very refractile.
right.
And where you were, that one's intracapillary there.
This one is intracapillary, right? So it's like almost a hyaline thrombus.
Well, yeah, in the
It's
setting
a hyaline
in the
appearing
setting of
thrombus.
lupus,
Yeah.
we call it but in the setting of you suspected CLL, then we would call these cryo.
Cryo. Okay.
Yeah.
And also it looks like they are in the capillary walls as well. These capillary walls look very, very thickened. Around this glomerulus, there is lymphocyte, or there is cellular infiltrate. They look like lymphocytes mostly. I don't see any eosinophils or anything else. The tubules look okay. Here's a proximal tubule here. It looks fine. So far I see this pattern of lobular glomerulus with hypercellularity and cryo.
Yeah, MPGN pattern, like you suspect.
MPGN.
Yeah.
I'm afraid of using that word now since Dr. Glassick doesn't like it.
Okay.
we're all afraid of Dr. Glassick, so don't feel bad.
This is I think this is the same
PAS
same
one.
stain.
It nicely highlights that intraluminal thrombus.
Yeah, right here at 6 o'clock.
Yeah.
It's very nice intraluminal thrombus there.
Yeah.
Everything else we've already talked about.
Yeah.
Here's a Jones stain. Again, you can see these thrombi, these cryothrombi, cryoplugs in these two capillary lumen. There's one over here. There is mesangial transposition. It looks like the mesangial cells of there's double contour actually here. There's double contour here at 3 o'clock and here again.
Yep.
I don't see any breaks. I don't see any holes or spikes. So that's mainly the double contours on this plus the thrombi.
Yeah.
Here is a low power stain again. This is again the left and the right, two really very densely packed infiltrates. I mean, it's so dense, it has to be leukemic infiltration. I can't imagine this would be anything else.
Yeah, I agree. When they're this diffuse and dense, it has to be a neoplasm. So we'll go to higher power and see the cells.
Okay, so it's kind of like that sheet of lymphocytes, right?
Yeah, so these are small lymphocytes, and notice how they're we call it monomorphic. They're same size and same shape. So
They
same
all look
protein.
exactly the same. There are no
Yeah.
plasma cells or anything.
Yep. And then this is the phenotype of CLL, positive for CD20, CD5, and CD23. And in the top right, the CD3 stains T lymphocytes. You can see there's some kind of few scattered T lymphocytes, but they're mostly this B cell clone.
Okay, so
Yeah,
this
so this is
confirms,
diagnostic
this
of CLL.
confirms CLL infiltration in the kidney. I can't remember if the kidney size was enlarged or not. Sometimes on ultrasound the kidneys look enlarged, but that's not necessarily, doesn't have to be.
They were normal.
They were normal. Okay. So we have IgG, which is positive in these segmental areas. And these are the same areas where we saw the cryo, correct?
Yeah. Although this is a different glomerulus, but
Okay.
yeah, it does have this kind of segmental staining pattern.
Okay. IgM is also positive. It's granular. It's capillary wall.
Yeah, this might be more of kind of trapping because it's kind of focal, not
Okay.
really diffuse.
IgA, same, positive, granular. This does not look like trapping. This looks like an actual deposition, correct?
Yeah, I mean it
is focal.
It's kind of weak, and focal. Yeah.
Okay.
Yeah, it may be focal, but it wasn't like the IgG was screaming at us either.
Yeah.
Right. This is definitely positive. Again, we have we have C3, IgG, mild IgM, and IgA all, but C3 and IgG mostly.
Yeah.
Kappa and lambda are both positive, so there is no restriction. Although we were sort of expecting because the blood looked like had IgG kappa, correct?
That's right.
Yeah, okay, but I see some lambda here too. Here's EM.
This is really low power.
Yeah, this is very low power. There's like
you can
a
actually see the grid.
British flag sitting on top of it. Let me see what's Yeah,
But
I'd
but
rather
there's
just go
no-
to the next power. I can't
you-
like really figure out what's what here.
Yeah, there's no nothing organized screaming out to you at this even
Right,
at the
not
low
from this
power.
power.
Yeah.
Let me see. Okay, here's a higher power. Yeah, I don't see. So here's a basement membrane. This is the capillary lumen. So this is the this is the capillary side. This is the urinary side. There is this, a huge amount of cell processes in between the basement membrane and the lumen. So this is mesangial transposition, right?
Yeah.
Interposition.
I'm sorry,
Yeah.
mesangial interposition.
Yeah.
I don't see podocytes. It look like they've been lifted off.
Yeah, it looks like the tissue is poorly preserved.
Yeah. Okay, so I can't comment on that. But if I had to guess with 8.5 grams, I would say they're probably effaced.
Yeah.
So Casey, what are you going to call this pathologically?
So I'm going to call this CLL infiltration of the kidney plus MBGN pattern of injury plus cryo.
Yep, I agree. Yeah, nice reading, Casey.
Anybody disagree?
Well, I'd like to ask whether it would be useful to do pronase digestion and paraffin IF.
Okay, let's go to the next slide. So poll number one. I didn't set him up, by the way.
Yeah.
Poll number one, would you, there's no more workup needed. It says lymphoma, treat the lymphoma. Number two, pronase digestion immunofluorescence. Number three, repeat the cryoglobulins at Rush University Medical Center under the guidance of Dr. Corbett, who I can assure you will deliver them in his axilla, or plasmapheresis and treat the lymphoma.
That was when we did the cryos ourselves.
That's actually true.
Dick
had a lab. Yeah.
Dick did all the cryos in our own lab, and he made sure that we brought them up warm and that they clotted warm for several hours before he put them in the refrigerator, and before he spun them down and put them in the refrigerator.
Boy, I forgot about that. Yeah.
Well, we used to do all the serologic stuff. That was the days before centralized labs. So each subspecialty lab did their own tests. We did, crithidia and
Oh my
complement
goodness.
levels.
Yeah, and he would do the immunofixation on it as well. Right?
Yep.
Yeah. Wow, boy. Woof. Our little lab on 5 Rawson. Well, that brings back memories. All right, I think we can we got a pretty good response here. You want to share it?
Yep. Ignore the other two. The first
Yeah.
four choices.
So I don't know if Dr. Glassick could set this up. So our highest vote is for the pronase digestion. And there was some people wanted to go ahead and pherese despite the absence of a circulating cryo. Some people want to repeat the cryos at Rush, and some people say, I got enough, just go ahead and treat. So I think it's a good question. Next slide. Casey, what do you think?
Well, I mean, the treatment
you
is
vote
not
for?
really, the treatment is not a question. I mean, the patient needs to get treated. So I think, and I'm trying to see if doing anything else besides, just treating the patient is gonna change management. And I feel like I'm gonna just go ahead and treat. Even if I get pronase digestion and I'm able to pull out a restriction from the immunoglobulin standpoint, is that gonna change how I treat the CLL? Probably not. So I'm gonna go with just treat.
I certainly, as I look at that immunofluorescence, it's not impressive. There's no restriction. And, I think that's often a time we've made the point when things don't make sense, do pronase digestion. So I can see why that would help us, but I think your point's valid. Maybe we have enough information. We should just treat. None of these are mutually exclusive, by the way. I also want to repeat the cryoglobulins under Dr. Corbett's fine guidance. And plasmapheresis is an interesting thought. We'll get into that a little bit later. I'm not sure what you're pheresing, but that's not an irrelevant thing to be considering here. Now, here's the catch here is that I need to come clean right now, because this is a case that Dr. Corbett saw 5 years ago. It was from 2018. Pronase digestion was not on anybody's radar at that point. In fact, kind of the broader concept of monoclonal gammopathy of renal significance was just coming into favor as well. And I think this was really just considered a lymphoma, kind of like number one. We've got our diagnosis and let's go with it. Cryoglobulins were repeated twice at Rush and they were still negative. Plasmapheresis was not considered. And so the answer at that point was no more workup needed, treat the lymphoma. And I'll show you what happened here. So here you can see, yeah, you can run these slides. Just so, as we start on steroids and obinazumab, which is a anti-CD20, human anti-CD20 drug. His creatinine started coming down nicely. That was followed a few months later, 6 months later, by rituximab. I'm not sure why that was switched. That's a mouse human chimera anti-CD20. Maybe it was a matter of getting it approved. And then he was put on venetoclax, which is a BCL2 inhibitor. BCL2 is a protein especially rich on CLL cells, and it's kind of a protein that a survival protein. So it makes it less sensitive to chemotherapy, and just in general, it will have some cellular death. So it's an oral drug that I think they take every day. And so he's put on that for about a year. And after about a year and a half now, so he had 6 months of 12 months of monoclonal antibodies and a year of venetoclax, he was thought to be in remission. His creatinine was normal, and that's where we stood. And now let's go to protocol number 2. If we can, Dr. Mova, can read that for us?
So 5.5 years have passed since his CLL diagnosis, and he has been in remission for 4 years. Shortly after finishing treatment in 2019, he was diagnosed and treated for pulmonary blastomycosis and received 6 months of isavuconazole. From that point on, he was fine, playing tennis several times a week. In August of 2023, he noted edema, and he saw his cardiologist, who ordered lab work and found his creatinine to be 2.0. His recent baseline was 0.8 at that time, and a potassium 6.3, and he was admitted to the hospital. His proteinuria had slowly decreased from diagnosis at 8 grams to 1.2 grams last checked in 2020. Review systems was negative for any fevers, chills, weight loss, chest pain, dyspnea, palpitations, PMD, abdominal pain, nausea, vomiting. He did endorse bilateral lower extremity edema and some fatigue. Talking about his past medical history, is known diagnosis of CLL, MPGN, pulmonary blastomycosis, DAD, type 2 diabetes, hypertension, BPH, and OSA. His medications at the time were amlodipine 10 milligrams, Coreg 3.125 milligrams BID, Cardura 2 milligrams daily, Flonase daily, Losartan 100 milligrams, Crestor 5 milligrams, Lantus 20 units nightly, and Humalog TID, and herbal calciferol 50,000 units weekly, and a multivitamin and magnesium. And with his history of, he does have a history now of rash with sulfa antibiotics. So social history and family history unchanged. On exam, blood pressure 147/80, pulse 64, height 5 feet 6 inches, weight 74 kilograms, BMI of 26.3. His alert on exam, no lymphadenopathy, lungs are clear, cardiac exam unremarkable, and abdomen with no exam. I believe he did have +1 pitting edema below the knees and no rash. On lab and imaging workup is sodium 136, potassium 6.3, chloride of 107, bicarb 22, BUN of 57, creatinine of 1.95, glucose of 86, albumin of 2.8, calcium 9.7, Philly 0.6, alpha 71, ALT 14, and AST 35. CBC showed white count of 16.66, and 46% of that was lymphocytes. We did a peripheral smear that showed half of the lymphocytes had blastoid features, including open chromatin and prominent nucleoli, concerning for aggressive neoplasm. Hemoglobin 12.1, MCV of 81.1, and platelets of 181. IUA showed is specific gravity of 1.014, pH 6.0, 600 protein, 550 blood with 29 RBCs, 5 WBCs, and 18 squamous epithelial cells, and a few amorphous crystals. UPC to 10 is 8.6 grams. And serologic evaluation showed C3, C4, ANA, ANCA, RF, and cryoglobulin, Hep B and Hep C negative. Immunoglobulins were within normal limits, however, previously had been low. Serum immunofixation showed a paraprotein monoclonal IgG kappa 0.4 grams per deciliter, and urine immunofixation detected a paraprotein that was monoclonal IgG kappa. Flow cytometry was done and showed 69% lymphocytes that are kappa restricted, CD19 positive and CD20 positive B cells, which express bright CD5 and weak to negative CD38, consistent with CLL. Chest X-ray was done showing stable nodularity in the left-handed diaphragm, corresponding to the previous blood lymphosis, no pleural effusion, and retroperitoneal ultrasound would increase renal parenchymal echogenicity bilaterally, but no hydronephrosis. And right kidney measured 1.6 centimeters, and left kidney measured 11.2. CT was done. CT chest, abdomen, and pelvis showing lymph nodes increased in size in the retroperitoneum, several left para-aortic lymph nodes, right aortic chain and left aortic chain lymph node enlargement. Bone marrow biopsy was done on 9/1, showing relapsed CLL with cytological features of progression involving 30% of the bone marrow space with a nodular pattern.
So clearly he has relapsed after about 4.5 years. If you could just advance the slide, I'll give you a little more information here. So on the top, one of the things they would follow is his absolute lymphocyte count. And interestingly, for the longest time, it was it was low normal. And just at the very end, when he presents here, it's now starting to get abnormal, but nothing that impressive. His IgG levels had always been low, as was pointed out earlier, and it had climbed, but certainly anything very high. He did have, however, flow cytometry on both his bone marrow and his blood. The top is blood and the bottom is bone marrow. And in both of them now, 68% of the mature lymphocytes are kappa restricted. So this is hardly the same presentation as earlier, but clearly all indications point towards relapse of his disease. And so this came back very quickly. He was admitted, and very quickly this was figured out. The cytometry, the blood flow cytometry, is very quickly obtained, and he was given a gram of rituximab and a gram of salmeterol every day for 3 days. And that was pretty much at the beginning of, it's 9/1. It's kind of very early at where the creatinine starts going up. Next slide. You can see the creatinine is climbing now. Go next slide. And so here's the exact timing. He came in this sounds like a lot, but this is, only a couple days here for admission to when they got the bone marrow back with 68% clonal cells. He received the Rituxan and steroids, and they called us on consult. Meanwhile, he was given IV fluid, a lot of IV fluid. And so we were watching a little bit, and the creatinine seemed to come down, but then went up considerably and just kept climbing. Next slide. And so now, poll 2, would you hang in there? Lymphoma is the cause of this and has been treated, or would you repeat the renal biopsy? With a few more minutes here.
A good response rate already.
Yeah, I think that's going to represent us pretty well.
Mm-hmm.
So it's interesting that 83% want to repeat the renal biopsy. Well, I was the attending on this case, and I just kept watching the creatinine go up and watching the creatinine go up, and I really felt very strongly that number one is the answer. What are we going to possibly find? How's it going to change anything? We already know what he had before. What's the likelihood it's going to be different? Well, how would we do anything differently? But it just kept going up, and I thought, well, maybe from a prognostic standpoint, if nothing else, I'd want to take a good look. But I finally gave in and had the renal biopsy repeated. Casey, would you have repeated the biopsy?
It's a tough
Obviously, this
call.
is biopsy
Yeah.
conference, and we've got 20
Yeah, no,
minutes left.
besides that, just, if you were actually taking care of this patient in the hospital, outside of this biopsy conference, I feel like, how long did it take him to get better last time?
He didn't get very bad. He didn't get very worse the first time. It was only his creatinine went up a little bit, and it got better fairly quickly.
I mean, I feel like all those patches of infiltrate probably didn't go back to normal. So his degree of background fibrosis is probably higher now. So I wouldn't be surprised if it took him longer to get better, or he didn't get better back to his previous baseline. So I don't know if I would have biopsied him.
Fair enough. Dr. Reen, would you biopsy him? You're muted.
I don't know, to be honest with you, what the real answer is here. Probably I would have been pushed to do the biopsy too, so I think I'll consider biopsy. But Dr. Gashti's answer is also very correct. So,
Dr. Glassick, do you think there's anything to be gained from another biopsy?
Yeah, I would do another biopsy. This time I would do paraffin IF right off the bat.
Okay, so let's look at obviously there's another biopsy. Let's take a look at it. Casey, you're on again.
Okay, so here we got two cores. One of them is pretty much entirely medulla. The bottom one, it's trichrome, by the way. The top core.
Go ahead and click on the screen, Casey, and you'll control. Yep, there you go.
Okay, so the top core actually looks really good from a standpoint of fibrosis. I don't see a lot of trichrome staining. I actually don't see as much of a dense infiltrate as I saw in the previous biopsy. We have a couple of glomeruli here that look. This one definitely looks very large and abnormal, but I'll comment on it later. But chronicity score, I would say, still the same, 25%.
Yeah, even around 10%. Yeah, looks good. I agree with you.
Here, yeah, I guess there is some. I missed it on the higher power, but here's that monomorphic cellular infiltrate. We have some hyaline material inside of the tubules.
Highland cast.
Highland cast.
Yeah.
Are these look kind of fractured? Is this?
No, okay,
That's
we
not
could
it.
see that even in typical Tam Harsful cast.
Okay,
Yeah.
All right. And then there's one glomerular tuft that's hanging off the edge here, but I'll probably look at a different one. So this one is basically, we have the cellular infiltrate we had last time. We have it again this time.
Yeah. And I think we have, even a higher power showing again, monomorphic cells.
Okay. And the stains, I assume, are the same as before.
Yeah. Yeah.
Okay.
So recurrent CLL.
Okay. So far we have recurrent CLL. We still have that lobular pattern of glomerular injury. We still have the thickening of the basement membrane. We still have those thrombi. I can see here. I feel like there is more proliferation here. I mean, this area here, I see. Are these karyorectic debris, or are these just nuclei?
Some are neutrophils right in the center. It's some occasionally there is little karyorectic debris,
Okay.
but you're right that there's not an open capillary loop in the entire glomerulus.
Okay. Again, periglomerular infiltrate, tubules look okay. This is a higher power. We have the cryo again.
Yeah.
They look like they're kind of attached to the wall in the sort of the endothelial side. There's a thick deposit here. I don't know what these round circles are.
I'm going to get back to that. So,
Okay.
Just skip over that right now.
Okay. Yeah. Anyway, I guess I don't know what they are, but
I'll tell you in a little
okay.
bit.
Sounds good. Here's a PAS stain. Again, you see these intracapillary cryos that are plugging the lumen. And then that's kind of, that's the highlight of this, correct? David?
Yeah, and then also the mesangial above it. It does looks like the mesangium's kind of broken down. Yeah,
Here.
yeah.
Okay. More of the same here. Lobular pattern. I see neutrophils. I see hypercellularity. I see these thrombi throughout. No open capillary loops noted.
Yep.
This is Jones stain or silver stain. This looks very similar to the last biopsy. We have mesangial interposition. We have the thrombi, no breaks, spikes, or holes.
Right.
All right, fluorescent, IgG. Still positive, not as intense as last time. I don't know what this part was cut off. It looks like maybe there's more down here, but it's, I would call this positive.
Yeah.
Pretty
Even though it's
disappointing.
not as,
Pretty disappointing, though.
Yeah, it's not very much. It's just a few granules spread out, but nonetheless, it's there.
If you look at like 7 o'clock, I almost get the sense that there's a couple. Yeah, right there. That might be one of those blobs.
Bios?
Yeah.
Yeah.
You would think that would light up.
Right. Oh, you mean here this would light up. This would be the cryo.
That little where the arrow was. Yeah, right there. Exactly.
Here,
Yeah. It looks like a
Right,
little
right.
blob, like the
Right.
crowd. And you'd think if anything, it would light up. So it's kind of interesting.
Right. Now we have restriction. So kappa is positive, lambda is negative. Last time we didn't have this, so I guess pronase digestion, we may have to skip that. Kappa is positive inside of the capillary lumen.
Yeah, I thought this was a good example of the intracapillary cryo staining strongly for kappa.
Okay.
He's showing it at such a high power because most of the glom was negative. I'm telling you, the immunofluorescence is kind of disappointing to me. But what's your diagnosis?
No EM.
Oh, sorry, there was not enough sample for EM this time.
Okay. So it's same as before. You have CLL infiltration, you have cryo, and you still have that MPGN pattern of injury.
Exactly. And,
You know what I think is interesting?
Why
This-
didn't you call this proliferative glomerulonephritis with monoclonal immunoglobulin?
Well, because there's intracapillary cryoglobulins.
Well, okay, but the monoclonal cryo should be IgM if it's cryoglobulinemia. Correct?
well, if it's a type 1 cryo,
Unless this is
this is a type 1
an
cryo.
IgG kappa cryo in which it's type 1 related to
Yeah.
his, and I wanted to make sure that you were clear that this is a pattern of injury, but let's get a little bit more precise in the diagnosis. You think this is a type 1 cryo, right?
Yes.
And the cryo is an IgG cryo, not an IgM.
The IgG kappa, like he has in his blood.
Okay.
What I think is interesting, it's not really been talked about much, but here's a guy who's now had diabetes for years, and there's no pseudolinear staining for IgG. And in the first biopsy, where there was an electron microscopy, that didn't look like the basement membranes were thickened at all. So unless David tells us there was some pseudolinear on this, I mean, it's interesting that he has really no evidence of any kind of diabetic nephropathy, it coexisting with this other more important lesion.
So I was still bothered by this, this very unimpressive immunofluorescence. Now, you could say maybe if pronase digestion would have brought it out more, but like Casey pointed out, at least it was restricted on the light chain. So I don't know if it would have brought something more out in the IgG. I don't know if that's possible or not, but I was rather bothered by this. I stopped by to talk to David about it, and David brought up, what Casey noticed in these two glomeruli, these pictures here. I guess this is, I don't know if I had this in the original, but you can see that if you go, they look like protein reabsorption droplets, except it's in the wrong place. And so you go up on these in high power and you can see they're little like vacuoles, little
Granular deposit, yeah.
Yeah, granular collections of the same thing of the same color as the cryo. And he whips out this book, and I don't think it was Hypnostall, was it, David? It was a different renal path book.
Yeah, by Jeanette, yeah.
Yeah, and he goes and he shows exactly what's going on. This is in their chapter on cryoglobulinemia, and it shows again these little blobs that are there, and they call them phagocytes, or I think they're lysosomes are chewing up this deposit, and they're now deposited in these little areas. Is that a fair representation, David?
Yeah. They're within the monocytes that are digesting them. They're now within, the phagosomes.
So this is well described, and it made me feel a lot better about, the fact that this is a cryo, because, we're still left with this kind of odd negative cryo and type 1 and everything else. This is an EM. Unfortunately, we don't have EMs. It'd be nice for EMs for two reasons. One is to see if we can see us. This is the EM version of these blobs that are now within a monocyte. It would also be nice to see if there was any organization in any of the deposits, which you can often see with cryo. It's a very pretty picture when you see it. And they also in the book showed that these, as David mentioned, these are monocytes that are chewing up these deposits. So you could do a CD68 stain to show that there's a lot of monocytes in the glomerulus, which in 24 hours, David turned around in this case, and lo and behold, the CD68 staining was very impressive in this patient. I thought that was a really nice thing. Beautiful picture. Now, at least if there was any question in my mind that this was a cryoglobulin related GN, it may not have been anybody else's concern, but it was in mine. This really settled the score for me. And so we're really kind of left with the question. So we now have poll 3. Would you, again, hang in there? Lymphoma is a cause of this, and it's been treated. Number 2, recheck flow cytometry and decide what to do. Or would you add plasmapheresis now that you've seen these blobs in this patient? Remember, the creatinine is climbing fairly rapidly. Realizing if you pick number 3, I'm not sure what we're removing. At least we can't find anything in the serum, and we've done it multiple times. Okay, so what we've got here is about 2/3 say it is time to start plasmapheresis. A small percent wants to check the flow cytometry and decide. I'll give you that data shortly. And about a fourth says hang in there. Lymphoma's cause has been treated, which you could argue that all along at every level of this case. I'm going to, Casey, what would you do real quickly? Would you freeze?
No, I mean, he got better last time without pheresis, and he had cryo then, and he has cryo now. So I don't think that much has changed. And like you said, there's nothing in the blood. I mean, there is some. We're probably not just capturing it. It's either low level or we're just not doing the test right. But
you also mentioned it might be cyclical.
in the tissue.
Cyclical too. You did mention that possibility.
Yeah, it is cyclical, but it makes me feel more comfortable that he got better last time without pheresis too.
He wasn't this bad last time. He didn't have AKI to this degree last time.
Fair.
Dr. Reen, would you plex the patient?
You have a cryocurate level on him?
No, it's been negative 4 times now.
Okay. Well, I'm heading toward plasmapheresis because he's getting worse. He has been treated adequately. I will consider plasmapheresis, but I don't know what I am pheresing, that's for sure. But I will like to give him a trial.
Dr. Glassick?
Boy, tough question. I do know, or I seem to recall, that some of these type 1 cryos have very unique characteristics of thermal stability, and they can be easily missed when a standard approach is used. And I seem to recall a paper many years ago that the better test is the exposure of the blood to hypotonic fluids. You take the serum and put it in a bag, and then dialyze it against distilled water. And if you've got large amounts of cryos, they will precipitate even though the temperature is not shifted. So I would add plasmapheresis basically because I have nothing else to offer the patient. And I'm a little bit worried that the measurements that are being done in this case are not truly reflective of the serum load of a cryoprecipitate of some sorts. That's not a very good rationale, but I think what else do you have to offer?
Well, that was my feeling. I mean, I thought the guy's getting worse, and the minute I saw that going on, the creatinine go up, we decided to plasmapherese him. We do run the plasmapheresis at Rush, so it's very easy for us to order. It's relatively benign considering, and so we started Plex. It's a little more complicated than that. Here we could see that over the course of the 2 weeks, believe it or not, before he got the renal biopsy, they gave him so much fluid, he gained 50 pounds. And, in retrospect, I take some responsibility for that, for not getting involved sooner. But we started diuretics about 2/3 of the way through, and they weren't effective at all. So we started CRT at the time of the biopsy, both for a little bit of clearance because his potassium had been rising, but also so we could remove a lot of fluid because he was diuretic resistant. I mean, you look at those glomeruli and you can kind of see why there's not much filtration going on. So we had diuretics go, we started CRT, it started taking fluid off. So some of this decrease in creatinine is related to the fact that we were achieving extracorporeal clearance. But he got plexed. I put him back on some steroids, and he got better. And then Dr. Baxi was on and noticed at this point, let's just stop everything. And sure enough, because you don't know how much of this creatinine improvement is related to the old treatment or the plex or whatever. So he stopped it, or the CRT is what I meant. And so he stopped it, and lo and behold, he continued to get better and got significantly better. Credit my fellows for getting a 65-pound weight loss with CRT, something I don't think we could have done in any other way without the CRT. And then at this point, he was responsive to diuretics and would still lose 2 or 3 pounds a day. So very nice response. So here's kind of something interesting is his serum free light chain. They were never that high. And the ratio was a little bit elevated. This is back in his initial diagnosis, but then didn't really go up that, from that point on, these are really normal for his level of renal failure. Now I'll kind of get back to that. And now we're out 3 weeks after rituximab, and his flow cytometry is pretty much, his cells are gone. So he's responded to chemotherapy. Realized this was a week after the renal biopsy and a week after we started pheresis, so, had I had this information, I don't know. Would I have pheresed him? I don't really know. I think I would have. I just felt like I needed to do something, which is a really risky thing in medicine as a general rule. But I knew that if he had a circulating protein, I could remove it pretty well with Plex. So I have 3 rhetorical questions. Was the renal biopsy indicated? We discussed a lot of that last week. We kind of went back and forth. I don't know. Did it help me? I don't know. I think it helped me because it led me to do plasmapheresis. But that doesn't mean the plasmapheresis did anything. I don't think if I'd have done the renal biopsy, I would have started plasmapheresis because I really wanted to see that this renal biopsy showed the evidence that it did before of a cryo. But I still had a problem because the real question, which is not rhetorical, is how can you explain the histologic findings with the serologic findings of not having a circulating cryo? And Dr. Glassick brought up some of the possibilities there. So now we have 2 renal biopsies that show clear histologic evidence of cryoglobulinemia. I was completely convinced after I met with David, but the serum cryoglobulins are negative, multiple testing, 2 institutions. Rheumatoid factor is negative. Well, I often call it a poor man's cryo, but this is a type 1 cryo, so I wouldn't necessarily expect them to have rheumatoid factor. C4 was abnormal in the first time around, but normal on the second time around. But not cryoglobulins fixed complement, especially type 1 cryoglobulins. And as has been mentioned multiple times, cryoglobulin testing can be very finicky. So David also produced this article, which is extremely timely, which is out of course, Mayo Clinic, because they see more of these kind of things in pretty much anybody. And they described what seronegative cryoglobulinemia. And this was all these patients they were non-hepatitis by definition. And so a cryoglobulinemia, which was non-hepatitis related, hepatitis C related, and of the 81 patients, 22 of them were seronegative, meaning they had no evidence of a circulating cryoglobulin. And so they went to describe these patients, which is really what we're talking about here. Here's some of the pathology they showed, very similar to what we had: infiltration, lobular, cryoglobulin, thrombi, etc. No different than really what we saw in our case. And so there really weren't that many, very many differences between the ones that had a circulating cryo and those ones that didn't have a circulating cryo, except that the rheumatoid factor was much less likely in the seronegative. Kind of fits us, but that's maybe, you know, ours was a type 1 cryo, but it certainly fit ours because the rheumatoid factor was negative, when it's much more likely to in the seropositive with the circulating cryoglobulin. The free light chain ratio is very unusual to be high in the seronegative, which also fit our case. And the only other statistical differences between the two is that, no big surprise, the seropositive ones were more often to be IgM related. Kind of goes along with rheumatoid factor and everything else. They're IgG kappa on that for the most part. IgM kappa, more likely to be IgM kappa. So on immunofluorescence, there really wasn't a big difference. This is confusing. I'm going to skip this line here. But light chain restriction was more likely to occur, twice as likely to occur in the seronegative, which again was the case in our patient. And an IgM more likely in the seropositive, which we kind of already just discussed. So at least from what our case is, it kind of fit the pattern of what they'd seen. From an outcome standpoint, they separate here renal survival, but they separate at 10 years, and there's only a couple of patients, so it's statistically not significant. So there was really no outcome difference between either renal or overall survival between seropositive and seronegative cryo. But they did speculate on this whole business of a negative cryo. The article's now been posted. Thank you, Pravir. It says, however, cases that are histologically typical of cryo, but without serological evidence, are not infrequent in the clinical practice of kidney pathology. Well, it may not be infrequent at Mayo, but I think it's infrequent everywhere else. It's not infrequent in their hands because they see so much of everything. But I mean, they did have 22 cases over some, 30 years or something, it looks like here, 26 years, less than one a year. I wouldn't call that I'd call that pretty infrequent. Historically, seronegative activity for cryoglobulins in these patients has been ascribed to practical difficulty in detecting cryoglobulins, which they're assuming that's like what we described quite a bit of. What I thought was really interesting is that 2/3 of the seropositive cryo patients had extrarenal symptoms, but only less than 1/3 of the seronegative had extrarenal symptoms. And our patient really didn't have any, of the cryo at least, didn't have any rash or anything else going on. It was really his renal failure and his nephrotic syndrome that made him fit that. And so they make a really good point here that the lack of systemic symptoms and the lack of a circulating cryoglobulin often makes seronegative cryoglobulin a surprise diagnosis, because you're not really expecting it. You don't have a circulating cryo and you don't have any rash or anything else. And so therefore, the clinical suspicion before kidney biopsies with kidney limited seronegative is low. And therefore, the treating physicians are often skeptical of the kidney pathologic diagnosis, something I was a little bit myself and went to talk to David about until he convinced me, going through some of the other stains and some of the other literature on this. And you can see here that although supportive therapy was done in none of the seropositive ones, but in 3 of the seronegative ones, they didn't believe it, and they only treated with supportive therapy. So most got therapy, but it wasn't unheard of to do nothing because they didn't even believe the diagnosis. But what I thought was interesting, and despite of the fact that there was seronegativity, that still about 1/3 of these patients end up getting plasmapheresis, as we did here. And again, not having any idea if it had any role. Yes?
No, I was just going to ask you, how many of those patients in that paper were actually type 1 cryos as opposed to type 2?
I don't know that I have that. I don't think they broke it down that way. I did look for that quite a bit, and I couldn't really find that, because that would really kind of make you think that it even fits it more.
Well, for sure with hepatitis C, those are usually mixed cryos, like a type 2.
Yeah, that would be unusual, obviously, but they didn't really say what % of those were, or I don't remember. So some of the points, are that despite the absence of detectable cryo, blood and/or immunofixation allowed identification of a monoclonal in about 80% of them. It's most commonly IgG. This is of the seronegative ones. However, the size of the monoclonal protein is usually small and therefore vulnerable to false negative test results. That's one thought. The lack of detection of cryoglobulins may be due to low concentration of the culprit immunoglobulin serum or sickle variation, as Dr. Gashti mentioned, in the circulating cryoglobulin. Or maybe the increased intraglomerular concentrations of cryoglobulin reach during filtration. Remember, proteins get fairly significantly hemoconcentrated as they go through the glomerular tuft. Likely promote precipitation and could result in a high dilution of the serum. So you're right, basically pulling out a serum. It's almost like a sink phenomena that we describe with membranous, except more hemodynamically, precipitating them from ultrafiltration within the glomerulus. I thought that was interesting. But they said further studies are needed, which is always the last sentence of everything, determine if the monoclonal in these patients have a unique structure that could alter the physiochemical properties, which what Dr. Glassick was alluding to, allowing them to preferentially precipitate in the glomeruli. And of course, I left with a big shrug because I think this is left open. But it was a great case for us because we don't see a lot of this. Type 1 cryos are unusual. Type 1 cryoglobulinemia is unusual. And again, I don't know if Plex had anything to do with this. I'm glad some of the people agreed with me to Plex the patient. There was no question in my mind I was going to Plex a patient with zero confidence in my mind that I was doing the right thing. But that's often what we do in medicine. It's an art, not a science. So very happy with the outcome. He's doing quite well. His creatinine's down to 1.4. He's lost 65 pounds. His proteinuria, interestingly enough, I skipped over that slide, but the average proteinuria in these cases was a couple grams. His was 8 grams. And when he opened up, he was up to 16 grams. And then that's right when he first started making a lot of urine. We rechecked it last week. He's down to 8 grams, and I suspect that's going to get down considerably. And I think he'll do well. And I think they just have to follow him a little more carefully in the future and not let years go by between this, because I suspect this is something that's susceptible to relapse.
Dr. Radby?
Yes.
Didn't you present a similar case before? If I recall, about a year ago, who was cryo-negative patients and he responded to plasmapheresis at that time.
I don't know. We've had a type 1 cryo before. I don't know if that was also negative. This was 5 years ago. So this case clearly was before we started doing these online. So okay. I'd have to go look. I don't know. Pravir, do you remember?
Oh, I think that was one of the crystal cryoglobulinias. A little different, but it was a cryo.
Oh yeah, that's right. Yeah. That was crystal.
A little different.
Yeah. That was a case that actually required pronase digestion to figure out.
Yeah.
And I think it would be still interesting if pronase digestion was something I could easily do. I would love to see what the glomeruli would look like, but I don't question the diagnosis here. I mean, I think it's in one sense, it's CLL with cryoglobulinemia and GN. But then we're done and we don't have a good conference today and we don't get to look at the literature. I think it's amazing. I did a search right before here looking up seronegative cryoglobulinemia, and I found the only thing that came up was this paper. I found one other reference that had a few cases that that were a little bit similar but a little bit different, because all the seropositive ones in that case were those with hepatitis. So it would take the Mayo to have the kind of database to put this together.
I can add one small technical component, as I just did a little search. A long time ago, there was a series of papers describing hypocryoglobulinemia, in which when you dilute the serum 1-to-1 with distilled water before you put it in the refrigerator, that you enhance the ability to detect type 1 cryos. So this is a trick that nobody uses anymore. You just put the serum in the fridge after it's separated warmly and wait for the cryo to appear. Next time you have a patient like this, try diluting the serum 1-to-1 with distilled water before you put it in the fridge.
That's so funny you would mention that, because the title of this article, the one other that I was able to find, that referred to hypocryoglobulinemia, and I didn't look at them. I didn't look at the methods. And that may be exactly what they did.
The message is you can detect occult type 1 cryos by diluting the serum in distilled water prior to the time you put it in the fridge.
And why is that again? Why does that?
Hypotonic fluids increase the ability of cryos to precipitate in temperature when temperature changes. It's a physical phenomenon.
Yeah. I mean, I have to say, seronegative cryoglobulinemia is kind of like Congo reg negative amyloid or culture
Yeah.
negative endocarditis or normal glycemic PK. It sounds like an oxymoron, but
Yeah.
you know, you got to keep an open mind in medicine, and we're always learning. So I think I learned a lot from this case, and I appreciate everybody's input. So we're going to end it there. We should be back next week. Until then, I want to welcome our interviewees today. I hope you enjoyed the case too. And until we meet again, everybody stay safe.